The title of my talk is Endoscopic Treatment, Keeping It Simple and Smart. And that, after all, is what we always strive for with flexible endoscopy, trying to come up with methods of treatment that are clever and simple and can offer complementary treatment to surgery. Different treatment paradigms are rooted in the perception of what causes a disease. And for a long time, it was thought that there were evil humors in the blood that caused certain diseases. And therefore, bloodletting was practiced, actually over a period of some 2,000 years, from the time of antiquity all the way till the end of the 19th century. The treatment paradigm for obesity is also historically rooted in the perception that obesity is a problem of willpower. It's a matter of choice, an individual's choice to eat excessively. It is not a disease. And therefore, the treatment follows that the individual, the patient, must be forced to either eat less or absorb less. Now, this is one way you could get your patient to eat less. This is the anti-obesity mask. This is an actual patent. Now, there's no question, as ridiculous as this looks, this patient is going to lose weight. But is that anti-obesity mask all that different from these restrictive surgeries? A sleeve gastrectomy, where you remove most of the stomach, a lap band procedure, where you occlude the inlet to the stomach, or placement of a gastric balloon endoscopically, where you fill out the space of most of the stomach. Each of these are restrictive procedures, and although they may not be as visible as that anti-obesity mask, they are achieving the same objective, which is to get the patient and force the patient to eat less. Or we can be more humane and let the individual enjoy the pleasures of eating, especially as we come close to the holiday season. And we can force the patient to absorb less. And although this may seem to be better tolerated by the patient, it also comes with its set of side effects. We heard about malnutrition, and flatulence, putrid steatorrhea, and even some life-threatening complications, which is why we don't perform the jejunal ileal bypass anymore. This device here, that you will hear more about in the next lecture, the GI Dynamics endobarrier, was conceived with the objective of absorbing less. And you can combine both. You can eat less and you can absorb less. So we have the gastric bypass procedure that we've heard about today and the duodenal switch procedure, which combine elements of restriction and malabsorption. From the perspective of a gastroenterologist, which I am, rooted in internal medicine, obesity is not a surgical disease, it's a metabolic disease. There's not a diseased organ or tissue like an infected gallbladder or appendix or tumor that needs to be resected. And therefore, it's not logical to treat this disease with surgery. It's a disorder of energy homeostasis, really no different or analogous to diabetes, and a disorder of regulation of glucose, or hypertension, disorder of vasoconstriction and osmolality in the blood. There are physiologic pathways which we understand today that regulate appetite and energy metabolism, and these pathways are inadequate. In other words, in our man-made environment, where we have an overabundance of high caloric foods, and we have an excessively sedentary lifestyle, the body is not able to cope. Understanding the elements of the energy regulatory system is really key to effective treatment. And the good news, we're making a great deal of progress in understanding these neural neurohumoral pathways that you heard a little bit about in the first lecture by Dr. Cho that regulate appetite and energy metabolism. Now, all of you have heard about the gut-brain axis. That was the first to be described and has been the best studied. We know today that the stomach and the intestines secrete peptides that interact with the brain. There's the central nervous system and the enteric nervous system. We've even heard that there are more neurons in the enteric nervous system than the central nervous system. But we've also learned that there are other neurohumoral axes that integrate into the gut-brain axis, the gut-gut axis, where different organs that contribute to digestion interact with one another, and even different parts of the GI tract interact with one another. And there's even a fat-brain axis, where adipose tissue interacts with the brain and sends signals. So let's talk for a moment about the gut-brain axis. And I've outlined 3 different pathways here. And the first is the red pathway, which is the one that was first described, triggered by intestinal satiety peptides. Most of the neurons in the gut are concentrated in the duodenum, and they become progressively less as we go down towards the ileum. And we know that CCK, being the archetypal satiety peptide, it stimulates the gut-brain axis. But we've also learned that there are 2 other components to the gut-brain axis, and shown in green here are the intestinal incretin peptides, GLP-1 and GIP. GIP is actually produced in the duodenum by the K cells. And we have an intestine-brain-pancreas circuit, whereby the incretins, via the brain, stimulate the secretion of insulin from the beta cells in the pancreas. And most recently, we have discovered, shown in the purple, that there is another axis whereby intestinal lipid metabolites, this is long-chain fatty acyl coenzyme A, creates an intestine-brain-liver circuit, whereby glucose production in the liver is inhibited, and in addition, insulin sensitivity in muscle and other tissues, in peripheral tissues, is enhanced. Let's talk about cholecystokinin. This was discovered 3 decades ago, and it is the archetypal satiety peptide. So what happens? Well, free fatty acids and protein that are ingested enter into the duodenum, and essentially immediately the body converts from the ingestion phase to the digestion phase. These stimulate CCK, which is released, and CCK functions as both a hormone and a neurotransmitter. So as a hormone, it is absorbed into the portal circulation, where it has effects as a satiety agent, but also, and more importantly, it functions as a neurotransmitter and stimulates the afferent vagal nerve and has an inhibitory effect on eating. We know that it has both a role in satiation, which is reducing the meal size, so to stop eating, that's the immediate effect, but it also has a role in satiety, that is to suppress hunger before a meal. Now this is a busy slide, but I show it to you because I want to emphasize the very central role that CCK plays here. So as you heard, CCK will inhibit appetite and energy metabolism. It will also inhibit the stomach, so it inhibits gastric emptying. It actually stimulates the pylorus to contract to prevent emptying. And we know the different organs that are affected by CCK that have a stimulatory effect, so the production and the release of bile acids and gastric juices and contraction of the gallbladder. Importantly also, CCK does stimulate the beta cells of the pancreas, so it is also an incretin hormone. CCK is the only recognized physiological satiety peptide. Now, of course, we understand that there are other peptides that appear to play a role, but I emphasize physiological. Administered in physiological doses, it functions as a satiety peptide. There's a temporal link between nutrient-stimulated CCK secretion and inhibition of food intake. When we infuse CCK at physiological doses, it reduces food intake and stimulates the feeling of fullness in humans. And in fact, in animals, it reduced intake in animals that were sham-fed, that is to say, they had open fistulas. And when we block the CCK receptors, this is the CCK1R receptor, this antagonizes the satiating effect of CCK, and it increases meal size. And in fact, in animals, the animal will eat incessantly, will develop hyperphagia, won't stop if you antagonize the CCK receptors. We discovered leptin in the mid-1990s at the Rockefeller Institute. We know today that adipose tissue is also an endocrine organ, and it has an anorectic effect. What we understand more recently, however, is how leptin and CCK interact. And in fact, leptin potentiates the action of CCK not only in the central nervous system, but also in the enteric nervous system. So leptin appears to have a permissive and accentuating effect on CCK. I believe that the duodenum is where the action is, and I think it's logical because that is, after all, where bile and pancreatic juices mix with the macronutrients to start the process of digestion. Now, what's the evidence? Well, we have pyloric occlusion, or what are called cuff studies, in rodents. This is back done in the 1990s, and they took animals with their cuffs open, and they compared them with animals with closed cuffs. And interestingly, the animals with cuffs open, meaning that the nutrients could enter into the duodenum, they ate less than the animals with cuffs closed where the pylorus was obstructed. You'd think, of course, just the opposite. We have evidence from sham feeding experiments in rats that have open gastric fistulas. This was all done in the mid-1970s. If you infuse food into the duodenum in sham-fed rats, this inhibited their feeding. Interestingly, even if you infuse CCK intravenously, this also inhibited feeding in sham-fed rats. Now bear in mind, all the food that the rats are eating is immediately taken out of the stomach because of the fistula. And now we have clinical studies. For example, in this study, they took 20 males, volunteers, and they infused lipids or glucose or saline into the duodenum. And what they found is that the lipids decreased the intake or the sense of satiation by 22% compared with the control saline. And lipids decreased the intake by 15% compared to glucose. In effect, what this is telling us is that the duodenum is also a calorie counter. It's responding not just to the nutrient, but also what the calorie content of the nutrient is. And we have this study whereby they infused glucose into the duodenum, and they found that it reduced hunger and food intake, whereas intravenous glucose, that is, infused into the portal vein, had no effect. And finally, to highlight the emerging role of the long-chain fatty acyl coenzyme A, which is a metabolite of fatty acid produced in the duodenum, there is this study that showed fairly recently in 2008 that direct intraduodenal administration of lipids increased long-chain fatty acyl coenzyme A levels and suppressed glucose production. That's the intestine, brain, liver, neural axis that I showed you earlier. The ideal endoscopic treatment should follow a physiological mechanism of action. It should preserve normal anatomy, and specifically allow the patient to eat normally. It should maintain normal absorption. It should have no adverse side effects, and it should be adjustable. A smart endoscopic device, therefore, should enable a physiological mechanism of action. It should be simple in concept. It should be easy to deploy endoscopically by the endoscopist on an outpatient basis. It should be a quick procedure. It should not require any special skills or equipment, and ideally it should be removable. Now, this is a concept of a duodenal flow restrictor device. The device reduces duodenal flow. This increases the contact time of the byproducts of nutrition, so fatty acids and proteins, amino acids, and glucose. And these stimulate chemoreceptors in the duodenum that have been well described. And it may distend the duodenum, stimulating baroreceptors that respond to distension and pressure, as well as mechanoreceptors. These will trigger the release of CCK, GIP, the K cells, these are the I cells, as well as the long-chain fatty acyl-CoA, in turn resulting in satiation and satiety, and it will have an insulinotropic effect. And the device itself, being in contact with the duodenum, may also stimulate mechanoreceptors. This is what such a device could look like. Here you can see it has a C configuration so that it becomes self-anchoring in the duodenal C loop. There are no barbs, there are no invasive components to this. It sits alone in the duodenal C. It's a near-closed C configuration. And here are spheres. These are expandable spheres made of a plastic mesh. And these spheres serve as speed bunks to delay the passage of the ingestate through the duodenal C, where all of these receptors reside. And this is, in this animation, how one might envision such a device working. So we advance our endoscope into the third portion of the duodenum, and then we can push this device through the working channel of the endoscope, and we retract the endoscope while advancing the device out in a one-to-one fashion, no different than placement of a stent. And here you can see the spheres deploy. It's a mesh, an open mesh. So these spheres will actually retain the ingestate within it for a longer period of time, as well as serving as speed bumps to delay the passage of the ingestate. So there's a longer contact time with the duodenum. And the ingestate that is retained in the spheres will have an ongoing effect on these receptors after the patient has stopped eating. Basically, we're not affecting the hindgut. We heard about the hindgut theory. We know that secretion actually occurs prior to direct distal intestinal stimulation by digestate. And you wonder then whether the mechanism is actually mediated by peptides like CCK. We know that pharmacologic doses of PYY are needed to induce satiety. And GLP-1, its main role is as an incretin. It's not a satiety hormone yet. And I call your attention to one randomized trial that compared sleeve gastrectomy with gastric bypass. No difference. This is the study from Zurich, Switzerland, published in the Annals of Surgery, 27 patients randomized to bypass versus sleeve gastrectomy. Similar excess BMI loss, both markedly improved glucose homeostasis, and at 3 months, no significant difference in insulin and GLP-1 secretion. Again, a randomized controlled study. Let me conclude by saying that obesity is a metabolic disease. It's a dysregulation of energy homeostasis, and that's how we should view it. Gut peptides clearly play a key role in energy homeostasis. That's where a wealth of knowledge is emerging. In summary, the gut-brain axis, the production of satiety peptides and incretin peptides, the role of long-chain fatty acyl-CoA generated in the duodenum that stimulates the intestine-brain-liver circuit. This is emerging, and I'm sure we'll hear more about this. But what we need are smarter therapies that target these physiologic pathways to regulate eating and energy metabolism. Thank you very much.